Aloha! This CME activity is jointly provided by the Queens Medical Center and UH-JABSOM Department of Geriatric Medicine. As a reminder, evaluations are required for certificates of attendance. After you complete an evaluation, a certificate will automatically be sent to you. You can find evaluations by following the link in the chat at the end of the session or at any time on our website and email advertisement. We are on month 2 of a 4-month series on the mind. In the evaluations, we will be asking you about how many of your residents have been screened for dementia and depression and how you assess for delirium. Someone will be staying on after with you to show you how to complete the evaluations. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO model goes, all teach, all learn. So it will take all of you to create this community of learning. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open up the time for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to topics of today's lecture. We only ask that you keep it HIPAA compliant. That means please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Wynette Gaylord, President of Care Home Operator Association. We have Maribel Tam, President of a Foster Home Association, Danielle DeLonghi from Aloha Care, Leila Ventar from United Healthcare, and Dr. Ritabel Fernandez from University of Hawaii. We just finished a 4-month series on medications, and if you're interested in viewing any of those lectures, you can find them on our website. We cannot offer certificates of attendance for videos you have viewed. Unfortunately, you must participate in our education live. We are now on a 4-month series on the mind. This month, we will be talking about recognizing delirium. Now it gives me great pleasure to introduce our speaker for today, Dr. Aida Wen. Dr. Wen is an associate professor, Department of Geriatric Medicine, John A. Burns School of Medicine, JABSOM, at the University of Hawaii. She is currently the PI for the Geriatric Workforce Enhancement Program, GWEP, and is also the program director of the Geriatric Medicine Fellowship Program. She is a strong advocate for improving geriatric and dementia care, striving to help patients and providers help seniors age as gracefully as possible. Take it away, Dr. Wen.
Thank you. Thank you so much for your very generous introduction. I am always excited to speak to you guys. This audience is the best audience ever because you have such great experience to share. I'm going to try to share screen here. Here we go. Okay. And today we are going to talk about delirium, how to recognize delirium and how to report delirium. These are our learning objectives: how to recognize it and know the common causes of delirium. And then we'll walk through how to report it and know the TADA method of management. Okay, here's the case scenario. Maybe you guys have they find this familiar, right? It's Saturday afternoon and Mrs. L refuses her meds. She tells you it's poison. And she throws her glass of water at you and demands to be let out of this prison and threatens to call the police. She's been eating less for a few days and she refused breakfast this morning because she wanted to sleep. She has had difficulty answering questions and following directions, and this is not like her. How many of you have seen somebody like this before? Right? I'm sure some version of this, right? And what do we call it? Some of us call it sundowning, right? When the sun sets, oh my gosh, right? The wolves come out and they start moaning, right? Yeah, so this is called sundowning, but the other word is delirium. All right, so how do we recognize it? What is it, right? What goes on? So these are some of the key features of delirium to recognize. So there's basically 4 features to keep in mind. The first one is that's acute. That means it's sudden onset or fluctuating. So this is a new behavior in the last 24 to 48 hours. This is not like her at all, right? Level of consciousness, attention, or thinking that fluctuates during your interaction with this person. And the second major feature is inattention. So very distracted, can't keep track of the conversation and can't follow directions, can't really hold the conversation at all. Okay, so these two. So the key features of delirium, we have to have 1, acute and sudden onset, and also very distracted, poor attention. Okay, and then the other thing to look out for is either psychosis or change in level of consciousness. So what do we mean by psychosis? Psychosis, you can recognize because they have lost track of reality. They have hallucinations. So they're seeing things that aren't there, right? They're hearing things that from voices that people are not there, right? And they have delusions. They have paranoid beliefs that they think somebody, they're fixed on a certain belief that that even when presented with very obvious data and examples, they still believe, they hold fast onto this fixed belief, and it's usually paranoia. So yeah, that's a delusion. And then disordered thinking is part of this psychosis. And, they're very confused. They think that, something like, oh, you're their husband or something like that, when you're not. Or the speech is rambling and going off in all kinds of directions. It's very unclear. There's no logic, and there's just like talking around in circles and going nowhere. Or the speech is very limited or very little speech. So they just might, 1 or 2 word mumble thing, and then that's it. So that's the disordered thinking and the psychosis. Or they have this problem with level of consciousness. So like a problem with the sleep-wake cycle. So one feature is that they could be hypervigilant or awake all night and restless, right? You've seen people like that, right? Who knows, right? They were fine, and then at night, man, they just kind of went crazy, hypervigilant. And then the other part is, let me see, there it is, hypervision. That's called hyperactive delirium, right? Okay. And then there's also something that we can see called hypoactive delirium. This is when they fall asleep on you. They're sleeping all day, much of the day. They may get up here and there to eat something, but maybe not. And then they fall asleep while you're talking to them, right? So that's called hypoactive delirium. And then, of course, there's people with both, right? They are sleeping during the day and they're awake at night, and they're crazy both times, right? And falling asleep on you. So that sometimes people can have mixed delirium as well. I want to point this out a little bit because this hypoactive delirium is very tricky. Sometimes when people go quiet on you, nobody notices because they're busy enough. They got all kinds of things going around. They're happy. This person's just sleeping today. Oh, they're just sleeping in. They're no problem at all. I'm not going to fuss with them, right? On the other hand, if somebody's doing some crazy things, they've got your attention, and there's something wrong, right? So you have to look out for that hypoactive delirium as well. Okay, so what are these 4 features? They're called the CAM criteria. This is the confusion assessment method, right? And this is often used in the emergency department or the hospital or nursing home when you got to take your person to get evaluated because there's something clearly wrong here. And then they confirm if there's delirium by using this CAM criteria. Now, but what if you're not in the hospital, you're in the care home, you're in the home, you're in the community, right? How do we recognize delirium with that, right? So there's something called the ultra brief cam, the UB cam. And it's really super quick. It's three items, and then it'll sort of take you down the path. So first ask this person, especially if they have previously cognitively intact and don't have dementia and they're able to speak. Have you felt confused in the last 24 hours? Is something not right in your head? You're feeling like a little bit more confused. Yeah. But if they're not, then you can say, okay, tell me the months of the year backwards. Let's start with December as your first month. And we'll go backwards. December, November, October, September, right? It takes a lot of concentration to go back. And that's sort of testing that attention part, right? And then you just observe them. Are they falling asleep while you're talking to them, right? And if these three questions, nothing, then they don't have delirium and you don't even have to do the cam. You're like, no, they're not delirious. They're just, something else is going on. But if they are a little confused, or they gave you some wrong answers here, or they fall asleep on you, if any of these are positive, then they might possibly have delirium and you should go ahead and do that cam that I showed you earlier. Now, fortunately, this is the, so this is especially helpful for outpatients and increased sensitivity because you can ask them a few questions before going down the whole path. So this is actually, I found out there's a new app. If you go online, go to your phone, right? And if you have an iPhone or an iPad or something like that, you can go to iOS and you can search up apps, UB-CAM Delirium tool. It's a free app and it just came out this year, 2023. And what it does is that it asks you the questions and then you click yes or no, present, not present. And then you just kind of go down the whole questionnaire thing. And then it tells you at the end, delirium positive or delirium negative. So it's kind of simple. So it goes through the UB-CAM, and if delirium is a possibility, like I showed in a couple slides ago, it automatically goes to the CAM checklist and highlights each delirium feature that you should be looking out for, and it automatically calculates it. So that's kind of cool. I was very happy to see that app, and if you download it, it's really easy to use. You can just test it out. So why is delirium so important to recognize? It's because it has to do with a medical problem, right? So the top 3 causes of delirium are drugs, infection, and abnormal labs. So some medications, if they were just started on a new medication about 4 days ago or something like that, and then suddenly they're kind of a little off, that's a top reason. Maybe we really need to reduce the dose or change the medicine. Infection, you've seen, right? When people kind of go a little bit, they're a little bit off, you say, well, better check that urine. Maybe they have a urine infection, right? That's a common scenario. Or maybe they have a pneumonia or something. And labs are like if they have a low sodium from dehydration or kidney failure or something like that, the calcium is off, then that needs to be addressed. So when patients start to have this delirium and you recognize it early, you can get medical attention right away. The sooner you get the medical attention, the faster this delirium can be treated and they won't be at risk for dying, basically, right? Because these things, if you let it keep going longer, the situation gets worse and worse. So here are other causes of delirium, right? There's stroke, seizures or other kinds of things that happen to the brain, heart attack, low oxygen, right? It might be a first sign of COVID or something, right? Low oxygen or pneumonia or flu, constipation or urinary retention. I've seen pure simple constipation. They haven't had a bowel movement in 5, 6, 7 days. and they start getting a little bit unusual, and then you disimpact, and then suddenly they're back to normal, right? So these things can cause delirium. So you have to get medical attention right away. That's why it's important to check and to recognize delirium. Okay, so this is look for early signs. So just have to be aware. This is the stop and watch early warning tool for nurse aides, caregivers, nurses, anybody who's taking care of some older adults. This is from the Interact tool. Stop and watch, which stands for they seem different than usual. Talking or communicating less than usual. Overall needs more help. Or pain or that's new or worsening, and less participation in activity. A stands for ate less. N is no bowel movements. D is drank less. W is a weight change. You're doing your monthly weight and you say, whoa, they're down 10 pounds. What's up? Right? A, agitated or nervous, more than usual. T is for tired, weak, confused, and drowsy. C is change in skin color or condition. They're kind of cold and clammy today, right? Or help with walking, transferring, and toileting more than usual. They're just needing more help. They're just overall, it's just not working for them. And if any of these things are seen, what should we do, right? We need to get medical attention. So we have to get ready to call. What do we do before we call the doctor, right? We got to get all the information down, right? So check those vital signs, right? You might be surprised. You might find out, oh, shoot, their blood pressure is super high, or could be super low, right? Or have there been any recent events? Did something just happen? Like they went to the doctor about, 3 days ago and they started this new antidepressant or something, right? Or did they go out with their family and went out and had lunch and we don't really know what they ate or drank, right? Any recent events that precipitated this? Any new complaints or new findings? Are they saying that they're, having pain here or there, right? Are there any changes in meds? And then have ready on hand their medical problem list, their allergies and their med list, because like we said, medicine, drugs are like one of the top 3 causes of delirium. Recent labs, if they recently had labs, so they can compare, because they can tell, if they have kind of kidney impairment, kidney failure, then they may be more prone to having certain problems, right? So having recent labs helps. Know their advance directives and any family contact information that they can give you. So you might give the family a call. So get ready to call, and then be ready to call with SBAR. Have many of you have heard about SBAR? I hope, right? SBAR stands for situation, background, assessment, and request. That's just an easy way to think about that. So here's the situation. Hi, doctor. This is Maria calling from Happy Care Home. I am calling about Mrs. L. The problem I am calling about is a sudden change in mental status. Just put out there, just that bullet. And then the background is Mrs. L had a hip fracture 4 weeks ago. And after rehab, she came to our care home. She also has a medical history of dementia, high blood pressure, and kidney disease. The only new medication is tramadol, which she is using for pain since her surgery. Right? She's doing pretty well until 3 days ago, where she's not eating or drinking as well as before. Then this afternoon, she became very agitated when we tried to give her meds. She believed it was poison, threw her water, and tried calling for the police. This is not like her at all. And for advance directives, she can go to the hospital for treatment, but she does not want heroics. So this is a very brief nutshell of all those things we talked about that's important for the doctor to know that raises our concern for delirium. Assessment. Here's your assessment. You took her vital signs. Her vital signs are good. Her temperature is 98.8. Blood pressure is 110/90. Pulse of 90. respiration 18, and oxygen is 97% on room air. Her weight is 135 pounds, which is unchanged. She's eating about 25 to 50% of her meals for a few days, and she skipped breakfast and lunch today. Her urine is dark, and she is now incontinent, which is unlike her. This is new. She has no bowel movement for 3 days. She's not coughing, and she has no pain in her hip or her stomach. And for symptoms, she is now hallucinating and calling for her husband, and she cannot follow directions, and she slept all day. That is what you observe. You've measured this, and you've looked at her urine and her bowels and her pain and her symptoms, right? You collect all this data and you let the doctor know. And the request is, you don't actually have to know what's going on. You say, I'm not sure what triggered this confusion. It's kind of sudden. I am worried about delirium. Doctor, would you like to see her? Or would you like her to go to the emergency room? And then, is there anything you would like us to do right now? Is there medicine you can prescribe in case the behaviors become dangerous? Right? And what's the treatment? Well, as we said before, because delirium is due to an underlying medical cause, the treatment is to treat the underlying medical condition. And hopefully, once you do that, the delirium should resolve. It should clear. Most of the time, it does. If you treat the pneumonia, you treat the urine infection, you fix the dehydration, they clear up. It might take a week or so, but they clear back up to their previous baseline. Sometimes delirium takes a little bit longer to resolve. Sometimes it can take like 3 weeks, and I've seen it take 3 months. And sometimes it never resolves, but that's a very small number of people. Most of the time, it resolves once the underlying medical condition is addressed. And what about treatment, right? When folks kind of start talking crazy, right? They said, Doc, give me something, right? So unfortunately, antipsychotics and sedatives are not the best options. They're only to be used if residents are a danger to themselves or to others, right? They start, throwing furniture or something like that, and they're really gonna injure somebody. Okay, so in the meantime, so if you find out, she's got this urine infection and the doctor starts her on this antibiotic twice a day for 5 days, and you're giving it to her, but you know what? She's really not even taking the medicine. She doesn't trust you. She doesn't want to take the medicine. She's not cooperative. She doesn't let you do pericare. She's just being difficult, right? You still got that problem there, right? You got to handle these behaviors until the medication all kicks in and the and takes care of that underlying medical problem for the urine to clear. So since this is temporary, right, we should actually try to tolerate the behavior. Just because they're talking crazy, you know what? If it's not dangerous, just observe them. If it's not hurting anyone, just nod, yes, 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 right? Tolerate it and allow them to respond to their environment as long as it's not distressing them. Right? Observe them. And you might actually get clues about what might be upsetting them. They might be telling you like, oh yeah, my stomach hurts or something like that, right? And say, oh, there's a clue. Maybe let's go look at her bowels, right? Or something, right? And then anticipate, tolerate, anticipate. So behaviors are a way of communicating. And if they cannot tell you, much like an infant or a toddler, right? They can't tell you. You need to think ahead to meet their needs, to offer them a snack or give them water if they're cold, give them a sweater, think ahead of them to meet their needs to avoid frustration and danger, because they are not going to be able to communicate that to you in their very unclear, confused state. So kind of like that, you have to think ahead and try to meet their needs before they get frustrated. And then Ta-da, D-A, don't agitate. So if they can't reason or understand, don't try. You know, if you keep telling them where they are, sometimes it can make them mad. It's like, stop telling me, right? Even reorienting them can make them upset. So for some people, it might help them. So you can go ahead and try, but if it's making them upset, you know, just stop. It won't help them and just make them mad. Just go with their flow, try distraction or try humoring the patient. So don't, so when you see these agitated behaviors, just chill, right? Ta-da, we'll tolerate it. We anticipate things, we won't agitate them. And hopefully in a few days when she's gotten the hydration, she's gotten the medicine, you know, we'll clear it up. It will clear up over time. We're just gonna see what we can do to prevent things from getting worse. Right, but she still hasn't taken her medicine yet, right? So we need cooperation here. So let's try getting there. So how do we get to cooperation? When you're feeling very confused, you don't know what's going on, right? And you get scared. And patients have a need to feel safe. Everything's very unsteady in their brain, right? So be aware of your body language, you know? Don't stand there with your arms folded and high over their heads, you know, get down, kneel, approach from the front, be aware of your body language, be open, speak slowly, speak calmly, right? Show empathy and respect and address their feelings. If they're, whatever they're feeling, say, yeah, I know it's a little bit scary, but you know, I'm here and I'm here to help you, right? Address your feelings and apologize and agree with them, right? They don't have to be right, but it doesn't hurt for you to agree with them, right? And then back off and try again later. You know, if they're not taking their meds right now, you know what? Try again in half an hour, try again in an hour, try again in 2 hours or 3 hours, right? You'll get there eventually. And hopefully with the persistent communication of care and concern, hopefully you'll get around to it. If they take a cat nap and wake up, they may wake up a new person, right? So show concern. Say things like, I noticed that you didn't eat breakfast this morning. I'm worried about you, right? So, or can I do anything to help you feel more comfortable? And then listen and don't dismiss them. Whatever their concern is, don't say, oh, you're just being silly. You're such a nervous Nelly. You have nothing to worry about. Don't dismiss them. Just address their concerns, address their feelings. And then take a very personalized approach. Don't do to them, do with them. So engage them and cooperate their partner with you. So use a favorite food or a drink. If they like ice cream, you know what? The medication can go with ice cream, right? If whatever their favorite thing is. Right? Or if there's a favorite person, maybe we need to call the daughter or the grandson right on the phone and get the grandson to tell him to take the meds. Or if there's a favorite music, have that in the background, put them in a good mood, right? And then later on, try again once they're in a better mood. Don't force them to do anything, just ask for permission and then redirect if they're going on the wrong path there. Right? Going on this path of anxiety or frustration, you need to like, oh, wait, let's not go there. Let's come back here. Consider things like music therapy with music that they like, or some gentle sensory stimulation. So these are things to just do. So this, you know, you'll recognize that this approach helps not just people with delirium, but people with dementia too, with advanced dementia, and they have trouble. But in particular, today I'm talking about delirium when this is not their usual self, they're a little bit off. This is a good approach to sort of get you over the hump until they can be restored back to their previous cognitive status, hopefully soon. Okay, and then I'm just gonna open it up. I'm sure you guys have lots of questions, and I know I already see some. So I'm going to stop screen share and let's talk story.
So someone says that their resident is always grouchy. So we have to figure out another way to go ahead and see how, or if they are delirious.
Yeah. So if you remember, right, the what's the criteria for delirium, right? They have to have, I'm gonna kind of go back and show this share screen.
So one of them was acute. I remember that.
That's right, right? You remember? So
Yeah.
is this behavior? He's always grouchy. That means this is nothing new. Nothing new in the last 24 to 48 hours. This is the same old, right? So probably it's not sudden onset. And are they having trouble with attention? Like can't follow directions, are very distracted, right? If they're always grouchy, is grouchy is not necessarily, you know, seeing things or hearing things or believing things that aren't true, right? That's different. So maybe, you know, Josephina, if you don't mind, you want to just share a little bit about what kinds of behaviors this person is having that that you want to review. Oh, you're muted. Oh, here's, you got, yeah.
Okay, whenever I talk to him, he's always yelling at me,
Uh-huh.
and there's no happy times with him.
Mm.
He even tell me to eat his ding ding. So I said, I don't eat sausage link. And it's not in the contract.
Okay.
No, it's not in the contract. I won't eat it. Yeah, he's grouchy. I said, why you always yelling at me? I'm not deaf yet, you know?
Mm-hmm.
But I think he's bored, but he doesn't want to go out too.
Yeah.
So what shall I do?
Yeah.
Well, he watches TV.
Uh-huh.
He watches porno.
Uh-huh.
That's it. He stays in his room because he doesn't want to socialize. He doesn't want anybody to bother him. Says, don't bother me, I will not bother you, kind of thing.
Okay. Yeah, so it doesn't sound like this is anything new, and he's not having this delusions or hallucinations.
Or sometimes he has.
Oh, sometimes he has, yeah, okay.
Sometimes he has, oh, can you check the roll towel that I put in my drawer? I said, you cannot even sit up. How can you put roll towel in your drawer? You know, so,
right.
Or sometimes he's asking me about anything else that I know he cannot do.
Right.
So is he on delirium when that happens?
Yeah, so he doesn't have delirium. So when you start to see, so what he my guess, I don't know because I've made assessment, but my guess is he might be depressed, right? And so you might have to assess for depression. But if he's not having this sudden new onset and he's having these, you know, changes, all four of these changes that you see here, it's probably not delirium. If you do see these changes, you say, you know what, I'm concerned. I'm going to call that doctor because maybe today's different and his behavior is not his usual grouchy self. This behavior, he has a medical problem and he needs to see the doctor.
Well, I tell the doctor that I think he's depressed.
Yeah.
But there's no medicine for that.
Yeah. Well,
he's taking a lot of medicines already. So I think even if there is, he doesn't want to take it because he's still alert.
Uh-huh. Yeah. Yeah. So that's a different problem. There's a lot of people who are depressed, you know. And so and medicine isn't necessarily you can't throw medicine at everything, doesn't solve every problem, but we have to figure out a different approach. So that's another talk for another day, right? About how to
it's very tough. when beautiful caregivers comes in.
Mhm.
When I terminate them, he's mad at me. He get mad at me because they say, why you terminated him? I heard there's a big boobs. I said, what? Well, you're looking about those things. I'm looking about the quality of their work and the HIPAA, you know. So that's where we argue sometimes.
Mm.
He loves beautiful women.
Yeah. Yeah. I mean, that's a challenging situation.
Yeah, it is. It is. Yeah,
You-
it's always grouchy, always yelling, though we're not deaf, you know.
Yeah.
I said, is that the way how you express yourself? Like yelling all the time? You make me like, nervous all the time because of your yelling. Now I gonna get PTSD or PSTD or something very soon, you know.
Yeah. Need to set some boundaries. Yeah. It sounds like. Yeah. Does but yeah, people have other questions or comments or cases to share of what you've seen and what you've tried.
For me, I try like being just humor. You know, I with this all these comments about me about I um I just um accept it like a joke from him. That's all I can do. Patience.
Yes.
Yeah.
That's a good strategy.
Mm.
Oh, Renata says redirect. Somebody, Ronald says move the guy out. Can we move him to
No,
the
it pays me good. So
facility?
I won't move.
Well,
Yeah, it's just scary sometimes. It's always yelling.
yeah, sometimes, I don't know, you have to try different caregivers, right? Maybe they respond better to men rather than women. Sometimes the other way around,
No, he loves beautiful women.
Most beautiful women. Yeah, somehow
He
maybe
loves big boobs.
he get some posters in his room. You can't touch any of your guys, your
When my
gals.
caregiver is giving him a shower, he's showing, he's pointing at her breast. Oh
Yeah,
man.
yeah. Have to figure out how to set boundaries.
Yeah, sometimes we caregivers we're about to have like harassment. They harass us. Even the caregivers that's coming, they
Yeah,
harass us too.
yeah.
Like
So
one one
Renata says redirect. I'm very curious what kind of ideas she has.
I don't know, but I taught him how to watch porno because he's lonesome. Ah, man.
So is Renata there so that she can elaborate on her comment about redirecting?
And
Reader.
Debbie says, divert client attention. Be prepared with a story that is appropriate. That will make him interact differently. Yes.
Oh well, he's so smart that he won't. He won't. He will dwell on that topic. He's so smart. He will just dwell on it till I said, hands up, I go out already.
Yeah, just walk away. Yeah, until he can behave better.
Mm.
But yeah. So yeah.
Also, be careful, my co-caregivers. If you have a hospice, CNAs coming, be careful with them, especially with men.
Mhm.
I got violated one time. He fondled me twice.
Yeah. No, I think when you have somebody like that, you have to, have a plan. Like, maybe you cannot go in the room by yourself. You always have to have somewhere,
No,
or you have to do it someplace a little bit,
my point is, he can do it to me. I'm still alert. How about those female clients that he take care directly,
Yeah.
That's my concern.
You have to find some boundaries. I don't know if people have good ideas they want to share also. Yeah, we are outside the topic. Don't encourage it. All right. Anybody else with delirium? Oh, good idea. Thank
So
you.
I have a question. So basically, if a person is delirious, they're getting physically violent because that's, maybe that's one of the things that's,
Mhm.
causing the pain is causing delirium.
Yes.
We have all of these aspects. When you call 911 because you feel that you're caught between a rock and a hard place, are you calling to get EMS in there, or are you calling for maybe HPD to come in? Or, how do you differentiate?
If you really believe it's delirium and this person meets the criteria for delirium, acute inattention, psychosis, or level of consciousness change, then they need a medical attention. They need to be taken to the emergency room. Because even if they, get the, medication on board or whatever it is, he needs a medical evaluation. He or she, patient needs a medical evaluation.
So how do they normally handle it? Say, for instance, if a person is getting physically violent because they are delirious, when you call, and sometimes you're on hold with 911, are you going to ask for EMS, or are you going to ask for HPD, or what do? You tell them what's going on? Because you're caught kind of sometimes in a rock and a hard place, because you have to think about the safety of the other residents as well.
I think the first thing you have to take care of is make sure that they're not dangerous. Once you remove the danger, then you can take care of the medical.
Okay.
So whatever comes first, it's got to take care of, remove the dangerous situation. Removing the patient, or removing whatever stuff around them, or whatever it is.
Okay.
Then
Have we found that COVID was causing delirium?
Oh yeah. COVID causes delirium, right? It causes it's an infection, it can cause trouble breathing, low oxygen, all of those kinds of things can, lung infection can trigger this confusion, acute confusion. And I've seen also not just kind of crazy ones, right? But the hypoactive delirium, where they suddenly go quiet on you, and then they stop eating and stop drinking, and they stop getting out of bed and stop all that, and they kind of go downhill that way. I've seen that too. And so even if they have treatment for the COVID and they get their Paxlovid or whatever, and they finish with that, they still stuck with the delirium that still needs to be managed, right? And needs to be handled for a while. Could be like a month, right? Because it can take a while to get better. Okay, Debbie says, give space, time out, and prioritize safety of others and the client. Yes. Yeah, if they're combative, walk away. As long as they're not hurting anybody, if they're not hurting themselves, back off, give them space, come back later.
Since we looked at the angle of COVID causing delirium, can we look at it vice versa? Does delirium cause COVID, or could it attribute to it?
No, COVID is a oh, well,
Respiratory.
Renata, yeah. So Renata actually also says that in some cases, COVID can cause encephalitis. In fact, she's right. COVID is what we call a neurotropic drug. It tends to attract to nerve cells, right? Which is why people had trouble smelling and tasting, right? It's all inside here in the brain, the nerves. And so they had trouble with the brain swelling as well as trouble with the smelling and the tasting, that thing. Yeah, so yes, it can cause changes in the brain, because not just because of infection and causes oxygen being low, but also because it's causing direct inflammation to the brain. So yes, that can be also the case. And so, treatment with antiviral medicine or monoclonal antibody should help that resolve faster. Other delirium stories?
Many.
Okay, so my patient goes into delirium every 3 days and has kidney failure. Is that normal? Okay, so Ronald, do you want to unmute and share your situation? Oh, here's Ronald. Can you share? Oh, I don't know how to, don't know how to hit the unmute button. On the bottom left-hand corner, there's a mute and unmute.
Hi, doctor.
Yes.
Hello?
Oh,
Yeah, I hear you.
My patient is taking Lexapro. So is sleeplessness is one of the symptoms, side effect, I mean.
Oh, of Lexapro?
Yes.
Yes.
Oh,
Yeah, so so if you suddenly notice a change, right? I think what you're seeing here, right? This is something that happened acutely. How long ago did they take start the Lexapro?
it's more than a month already, doctor.
Okay.
Because before that, doctor, my client wants to go out.
Uh-huh.
And she said she want to meet the husband in Capulani, but the husband is passed away a long time ago.
Mm-hmm.
So I called the Queen's Geriatric because I don't know what to do, doctor. Because one time she wondered, she went out, and my substitute never noticed that she went out. So the neighbor called the police.
Yeah.
So my husband explained to the police that, she want to go Capulani to meet the husband, and, the husband passed away already.
Yeah. Well, it
So
sounds like
that's why Queen's Geriatric prescribed that Lexapro for her.
okay.
And she's not like sleepiness and she loss of interest. She usually go after she eats. I like moi moi. I said, no, sit down for a while because you just finished eat. Just like she losing her interest to walk and do some exercise. So I don't know if that's the effect of the medicine also.
Okay. So yeah, so something changed after the medicine. And did she get more like, I know before you said she wasn't thinking right. Did that thinking get worse? It got worse?
She's taking no, she calmed down, doctor, but the only thing is seems more sleepy. She wanna go inside the room, do moi moi.
Oh, okay.
But she's taking only half, doctor, though.
Yeah.
This is 5 milligram, but she's taking only half of that.
Yeah. And is so she's more sleepy, having more trouble having conversations, or?
Yeah, doctor. She's more quiet.
Okay. Yeah, so if there's something, then it probably has to do with, it might be very mild, low level delirium, right? This is new. She's a little less attentive, and her consciousness is more sleepy. It could be. I would
Yeah.
say that definitely talk to the doctor and say, you know what, I'm concerned. This is effect of the medication causing her her change in her mental status. So should we try to change the medicine?
Yeah.
But you know,
Thank you.
that was very good that you observed that and you were able to
Yeah,
tell the
doctor.
doctor. Not
Yeah.
everybody picks up. Those are very subtle. So I'm glad that you were able to see that there's a change and we need to adjust. So let's see. What time of the day is a dose administered? That's true, right? Sometimes we if it makes them too sleepy, we give it at night instead of in the daytime. Right? Then you adjust the time. And if that takes care of it, then it should be fine. But if it's carrying over all day and all night and she's just continuously, sleepy, then that's a whole different story.
Yeah, because I give in the morning, doctor.
The other thing I would
I think
do, because sometimes that medication can cause a low sodium, is that the doctor might want to check her labs, her blood work and see
yeah,
how.
doctor. You know what? Sometimes,
Brilliant.
doctor, she complained, but she has a history of stone in the kidney, doctor. But doctor order or also the furosemide, half of the furosemide, because she complained she couldn't make sissy, so maybe it's the stone. Maybe the stone too that causing her not to make sissy, because she said, "No sissy, come out."
Yeah, well, sounds like there's a concern. You need to talk to the doctor about that.
Yeah, doctor. Thank you, doctor.
Okay, so yeah, sometimes chronic kidney disease and dialysis patient triggers delirium if toxins in their blood is high. Yeah, that's true, which is why sometimes when people have chronic kidney disease, we need to mention that to the doctor, because sometimes little changes can really mess up the way the body clears the drugs.
Thank you, doctor.
So yeah, so we have to be extra careful with people with kidney disease because we have to check their labs all the time.
Thank you, doctor.
What is the CBC with DIF? The CBC is a complete blood count with DIF, and it includes the white count, which has to do with your immune system, the red count, which is due to your anemia and your ability to carry blood across pump your heart. And the DIP is the differential. It just separates out which types of white cells there are. And chronic kidney disease and dialysis, kidney disease is associated with anemia. So usually you check the CBC if you're concerned about anemia. The CBC also has platelets, so that has to do with your clotting. Yeah. Oh, you want the results. Sorry. Okay.
Do we have time for Ronald to go into detail about his person that he's talking about?
Sure, Ronald, are you able to speak?
Yeah. So,
yes, please.
my patient was not chronic kidney disease, just the beginning of kidney failure. He also had a heart failure, some prostate problems. But what I would notice was that when he would get sundowners mostly every day, but it's like when he got enough rest, he would start going into this delirium stage where he would stay up for 24 hours basically. And like it was really interesting because he would start hallucinating and talking in bubbles, trying to play golf in his chair. But what I thought was also interesting was that he normally would fall asleep after I feed him. But when he would go into this delirium and I'd feed him a full meal, it wouldn't even make him tired. So that I let the doctor know about all this stuff. And my only question was like, should I have taken him to the ER or like when he went into the delirium? Because the doctor knew about the situation. She couldn't adjust the medication because with the kidney problems, he didn't want to exacerbate, make it worse or whatnot. So So like I just kind of had to, and I would do stuff like walk him during the day in the at
Mhm.
like 2.5, 3 hours a day before he would get the sundowners. And sometimes it wouldn't even matter. Like he would be exhausted. And then when that delirium hit, it's like he was Superman. Like I gave him like some I don't know. He was amazing though.
Mm-hmm. Interesting. Is this new for him, or is this the way he's kind of been for the last whatever year or two?
I only had him for like about 3 or 4 months, and then
Uh-huh.
he was just too much, so I had to get rid of him. But from when I first had him, the delirium didn't start until almost a month later.
Mm.
So it was um, I actually when he first got him, I actually told they started to kind of increase the meds. I actually decided to take the meds away because he was making him more confused.
Mm-hmm.
And then what I would notice was that it seemed like he would sleep good for 2 days and then go. And then he was also an ex-alcoholic. So I think maybe that had something to play with it, where, like
Yeah.
once
Mhm.
he'd get to that point where he's kind of confused a little bit, it's like he was at a party or something,
Mhm.
and he was
Yeah.
like drinking or whatnot.
So
And it just
yes.
progressed into this 24-hour thing. And I was like, wow, it's crazy. But
Yeah. So what it sounds like to me is that, you know, it's kind of a persistent thing. It's not something new in the last 24, 48 hours. This is just something that's kind of persistent for a while, like a month or 2 months, up to 4 months. And so he has psychosis. So, the cram criteria, there's like four
sure,
boxes.
sure, sure. Yes,
On the
yes, yes.
bottom left, there's that psychosis box.
Yes,
That's
yes.
where he
Can you put
lives.
this back in
Yeah,
my
yeah,
car?
yeah. He was. Yeah.
Yes.
He lives
Okay,
in the
okay.
I'll
That's
turn
what
psychosis
it was
off.
then, right?
So
Don't
he
forget that. I
has
don't want to carry it.
trouble with psychosis and he probably should be treated. So there's a lot of different reasons for
Mhm.
psychosis. Not
Mhm.
all psychosis is delirium.
Okay.
So that's just one box. And psychosis can be caused by lots of different things. One is alcohol, substance use. Psychosis, you and I can get if we don't get enough sleep,
Sure.
right? Psychosis can occur in people with PTSD.
Okay.
And psychosis can also occur in people with like manic depressive, psychiatric disorders or schizophrenia,
Mhm.
those types of things. And then all those should probably be treated, my guess, is with kind of more chronic meds, to get sort of so he needs to be seen by psychiatry.
Oh, I see. Because he was only, I had him go to a geriatrician, and they prescribed Depakote,
Mm-hmm.
which kind of would helped in the first couple of days, but after about a week, it wouldn't even touch him.
Yeah. Yeah.
So
So
okay, so psychologist next time. Okay.
psychiatry. Yeah, I think so. Yeah. So it sounds like, so he has a problem with psychosis, which is different from delirium. So delirium,
Okay.
but if you have psychosis, you want to rule out delirium, get him medically checked out. And if, he's got no infection, his oxygen's good, his heart's good, his congestive heart failure is not having a flare, then you can comfortably say, okay, it's not a medical problem. It's not his kidneys. It's his brain. It's a psychosis problem, and we need
Okay.
a psychiatrist.
That makes a lot of sense, actually.
Yeah.
I kind of thought it was his mind that just couldn't rest. That's what it kind of seemed like.
Yeah. No, you're right on.
Thank you very much.
Thank you, Dr. Wen. Thank you, everyone, for a great discussion. So just want to go over quickly the evaluation. And starting this month, please share with our team about the dementia and depression screening. So there are 3 questions here. I won't read them one by one. And then the next slide is please make sure that we have your correct email address and the correct spelling of your name, so that way you will be able to receive your certificate of attendance. And the last slide is there's a caregivers training or a support group. So the registration is here. I'm not sure if we're able to put that in the chat, the link, so they can click it there, or you can copy this and register for it. This is, oh, actually, this says May 25th. So I'm not sure if we have the correct date for this one, Dr. Wen. But this is through the Alzheimer's Association. Just didn't dawn on me. But anyway,
No,
so
that
again, thank you for your service. Uh-huh.
yeah, unfortunately that one came and went, but
Yeah.
yeah, but I think Wynette, did you want to make any announcements about your conference?
Oh, I'd love to. So ARCA is inviting everyone that's on this call today. We have our ARCA Educational Conference. It's an 8-hour event taking place at Philcom Center this week, Saturday, day after tomorrow. Starts at 8 a.m., ends at 4 p.m. We'll have a lot of great speakers, including Dr. Wen herself, speakers from Queens Hospital, Kaiser, Department of Health, OCA. So we're looking forward to our event, action packed. We're also giving away prizes. So if you do want to attend, go ahead and you can get in contact with me, myself, 808-227-7173. Or if you know an ARCA member, you can call out to them and they'll get in contact with me. But thank you very much. I'm not sure if Maribel is on, but I would like to do the closing if she's not. Maribel, are you there?
Yes, I'm here, but I cannot just. Sorry, I was in a meeting.
No worries. Take it away. Thank you.
Thank you, everyone, on behalf of the Hub team. Thank you so much. And thank you, Dr. Wen. Nice to see you again. And it's always great to have your in-services. That was so informative. So see you all again next month. And please do your survey so you can get your certificate. I'll see you on Saturday, Wynette. And for
Thank
all
you.
APA, for
We'll
all
see all of
APA
you.
members,